this lecture is the child with immunologic dysfunction. What we're going to cover in this segment is neoplastic disorders. We're going to start with leukemia and then we're going to move on to tissue and organ cancers. When you look at the information throughout the lecture, you'll see this periwinkle colored information. It's a little bit a different color than the other information in the lecture. And I just want to disclaim that this information is not from your text, it's from other sources. But I felt that it was information in helping put all the information together. So you should be comfortable with leukemia. I'm sure you've studied this in adults. Remember, leukemia is a broad term used for cancers of blood-forming tissues. And what happens is the bone marrow starts to make cells that don't immature appropriately. And those immature cells keep reproducing, and because they are reproducing so rapidly, they crowd out healthy cells, and they are in turn unable to reproduce efficiently because there's not enough space for them. In addition, the leukemic cells continue to reproduce. They send these signals to the normal cells that tell them not to reproduce, so it's shutting them off. And in response, they continue to proliferate and make more cells. So leukemias are the most common childhood cancers. They are more common in boys than girls, and you will notice that we actually have to treat boys a little bit longer than girls. The peak onset is about 2 to 5, and we classify them similar to adults. We call them ALL and AML. Interestingly, I know we've talked often about the little baby with Down syndrome and the little boy or little adult with Down syndrome, but I need to remind you that there's, again, Down syndrome children are 20 times increased risk for ALL. This is another one of their problems, in addition to hypothyroidism and congenital heart disease and risk for respiratory infection. Another thing that gets put on their checklist of things that we need to monitor for them and be alert for. These children primarily present with anemia. They may have low red blood cell counts. They may be neutropenic. They may have recurrent infections or signs of infection. In addition, they may end up with bleeding with some thrombocytopenia. So how do we diagnose it? Well, we have to look at a history. Frequently, it's based on clinical manifestations that trigger us to look for laboratory testing and to pursue it further. So children normally present with pallor, fatigue, weight loss. They may have anorexia. They may have hepatomegaly, splenomegaly, hepatosplenomegaly. Some may have lymphadenopathy. So they put these constellation of findings together as clinical manifestations, which raises their suspicion, and they look a little bit further to see if there's something suspicious of leukemia. So the first thing we normally do is just a CBC, and in addition to that, we need to do a peripheral smear. And that peripheral smear will actually look for those immature leukocytes that we talked about earlier. The confirmatory diagnosis is actually bone marrow aspiration. So in children, we have to take them to interventional radiology or take them to the PICU to sedate them so that we can do a bone marrow aspiration to confirm the diagnosis. In addition, these children are also treated with lumbar puncture. They just want to make sure that there aren't any cells in the CSF. So they want to rule out CNS involvement by doing a spinal tap. So once we've diagnosed it, how do we treat it? So chemotherapy, obviously, which you're familiar with in adults, this isn't really any different in children, except you have to think about how chemotherapy is going to affect a child who's growing. Just like radiation therapy, how does it affect the cells that are growing? How may it affect growth and weight gain if they have anorexia or they have recurrent vomiting and nausea? We give intrathecal medications and intrathecal chemotherapy depending on the CSF result and whether there is migration into the cerebral spinal fluid. We may treat it with bone and blood transplantation, bone marrow transplantation, biological therapies, blood transfusions, as well as antibiotics. So chemotherapy in children, again, really no different than adults, except we have those things that we really need to consider in children that are different. So first we start with induction therapy. It usually takes about a month, and our hope is that we get complete remission, at least less than 5% of leukemic cells. We do CNS prophylactic therapy, so we give intrathecal chemotherapy into the CSF. Then we do intensification therapy, higher dose chemotherapy. This may include bone marrow or stem cell transplant, which I'll talk a little bit about in the next slide. And then ongoing maintenance therapy to maintain remission. If you think about chemotherapy, we think about how it immunocompromises you. It makes you immunosuppressed. You have to think about infection control, reverse isolation, the importance of routine immunizations and not administering live vaccines. The other thing that I think a lot of students aren't aware of is when you do a bone marrow donation, you actually obtain the cells from the hip, and it is through bone. However, when you receive the transplant, it actually is given like a blood transfusion right into the vein. Obviously, if there is ongoing problems, there is a recurrence of cancer, you have to reinduct with chemotherapy after any sort of relapse. So when we think about chemotherapy and we think about leukemia, we obviously have a lot of education to do. We have the child and the family that we need to educate and prepared. These children will have painful procedures. They're going to have a spinal tap for diagnosis. They may need bone marrow aspiration to confirm their diagnosis. These are all painful and stressful and extremely scary. We have to prevent the complications of myelosuppression. We talked about the need for routine immunizations, but no live vaccines, monitoring them for infection and hemorrhage and anemia if those blood values are reduced. We also have to think about the administering of chemotherapy. We need to be handling it carefully. It's toxic. We need to make sure it's free-flowing, that these lines aren't infiltrating. Most children will have a central line, whether that's a port or a Broviac, so that we have free-flowing. We know it's a central line. It's a deep line. We don't have peripheral irritation of the site, etc. We need to monitor for anaphylaxis. These are big, heavy-duty drugs, and we need to monitor them as well, not only during the transfusion, but also afterwards as well, to make sure they're stable before we send them out the door, since many of these are done outpatient. We obviously have to manage drug toxicity. Again, not really different in children. These are just as toxic for children as adults, but we have children who are growing and need nutrition, so we have to address things like nausea and vomiting, anorexia. Many of these children will be pre-treated. Zofran is the gold drug for these kids. Treating them in anticipation of the chemotherapy, knowing that it's going to make them sick, is good, so that we can ward off any illness. Making sure they have foods that are going to make them feel good and appeal to them, letting them eat what's comfortable for them so that they get nutrition. The other thing is, a common thing for adults is we use viscous lidocaine to get rid of those or help soothe those oral ulcers that they get from the chemotherapy. We don't recommend oral viscous lidocaine in young children because they can't coordinate enough to understand how to swoosh and spit, and sometimes they will swallow and it actually impedes their swallowing ability because it numbs the back of their throat. So we don't give viscous lidocaine. And obviously, managing drug toxicity like alopecia, thinking about those things in advance and how we're going to address them is important as well. So next we're going to talk about brain tumors. When we look at the signs and symptoms, obviously they're going to vary depending on where the tumor is, the location, what is being affected based on that particular area of the brain, how big it is, and how old the child is. Because an older child can say they have a headache, but a younger child obviously is going to be irritable with a high-pitched cry, perhaps similar to someone with increased ICP. So the manifestations may change: headache, vomiting, neuromuscular changes, behavioral changes. Kids may fall off in school activities. They may have cranial nerve neuropathy, visual deficits. A lot of kids will complain of vision problems, double vision. They may have vital sign disturbances depending on how close it is to the cerebellum, and other signs such as seizures. So if we think about what testing we might do if we have a child who presents with these particular symptoms, and we suspect a brain tumor. Obviously, the first things we're going to do are imaging studies. So we're going to start with an MR or a CT scan and look and see if we can actually see a tumor on scan. In addition, we may need to differentiate whether there's vascular flow, whether it is actually a tumor versus a vascular defect. It could be an aneurysm, so angiography may be important. We may need to do an EEG if there's a history of seizures, or we know based on the location of that lesion that it may place them at risk for seizures and they may want a baseline. We will need to do a lumbar puncture to look to see if there's any seeding into the cerebral spinal fluid. And the definitive diagnosis for brain tumor is biopsy. So even though you see a tumor on CT scan, you need to do the biopsy, you need to send it for testing, figure out whether it's benign, whether it's malignant, look at the genetics of it. You may be able to genotype it to determine the chemotherapy, etc. But the definitive diagnosis is biopsy. So here's an image of a brain tumor I thought was pretty neat. And for those of you who may not be able to see it, there it is. So when we talk about the management for brain tumors, obviously there are a lot of different approaches, and it really does depend on where it is, what it's comprised of, etc. So radiation is good. Sometimes we start with radiation to shrink the cell and then do surgery. Sometimes we do chemotherapy to shrink the cells, shrink that tumor, and then do surgery. We can use chemotherapy. We may or may not use stem cell rescue. We can use surgery either through biopsy, through a resection. Sometimes we can use laser therapy to do a less invasive surgical intervention, and often it's a combination of all those things. We often use steroids because we need to shrink the tumors and we need to decrease the potential edema in the brain that could have neurological deficits. We obviously need to give really, really supportive care. Now, what's really important about brain tumors is many people present with deficits. That's how we find out they have this tumor. And many people think those deficits are going to disappear once they have surgery. Now, they may, but oftentimes they may not disappear, they may be permanent, or they may actually be worse based on what needs to be removed during surgery or how they tolerate the surgery. So that is really important from a realistic perspective to make sure that we're preparing the children and the families for what really is a realistic expectation for treatment. And the prognosis really depends on what is the tumor, where is it threaded within the brain, is it like a spider where it's woven in the brain versus a nice loculated tumor, how big it is, as well as the age of the child to see how well they can compensate for those potential deficits moving forward. So I told you I would talk a little bit about stem cell rescue and stem cell transplantation. So when we talk about stem cells and transplantation, we can do allogenic from other people, syngenic, which is when you actually transfer cells from identical twins. So when we do a bone marrow or peripheral blood transplant, we have to harvest the cells, we freeze them until we need them, and then we transplant them. So if we're talking about someone that is allogenic or syngenic, a non-autologous, I can't say that word, sorry, mobilization of cells, what they do, so someone who isn't affected with disease. They give daily injections of growth factor for about 4 days. Then they do daily stem cell collections. So they do this through apheresis. So they hook you up to a machine, they take out all of your blood, they filter it, they give you back everything but the cells that they need for transplantation. And it takes about 3 or 5 hours, and they do these collections depending on how many cells you need over 1 to 5 days in order to collect enough cells for to meet the needs of the person that they're donating to. Now, if you are doing it for yourself and you are disease inflicted, obviously you need to sterilize those cells. You're not going to implant yourself with your own cells that are indeed defective. So they give moderately high dose chemotherapy, followed by daily injections of growth factor. And then they usually collect about 10 to 14 days after chemotherapy. They will do the apheresis testing to harvest those cells. And then they do transplantation. If it's someone who is affected, you would do it about 2 days after chemotherapy so that you know that you've knocked everything out. And as I said previously, the stem cells are slowly reinfused through a central line. Again, the cells go through an IV line, they don't go into the bone marrow. So when we talk about brain tumors, we talked a little bit about the importance of understanding that surgery doesn't necessarily resolve symptoms. So good education up front is important. The other thing is having a really, really good baseline neurological status so you know where this child started preoperatively. So when the kid comes back postoperatively, you can know if this is a new or an improved function based on surgery. So it's really good to have that baseline as well as post-op for comparison. In addition, with brain tumors, as with many chemotherapies, but with brain tumors especially, we know that when they go to the operating room, they may need their head shaved. So figuring out what a child wants to do with regard to that up front, not having it be a surprise. So saying, do you want half your head shaved? Do you want your whole head shaved? Do you want to come back with a mohawk? We could do the 2 sides and leave the top long. Figure out what's fun for that kid so that they're involved in the decision making. Some kids are very happy. They know they're getting chemotherapy and they're happy to wear a hat. They're happy to wear a wig. They want to wear a scarf or a bandana. So talking about those options up front and figuring out what they want to do so it's not a surprise the day that they're going to the operating room. So again, we talked about those postoperative considerations, the fact that those deficits may remain. So obviously, vital signs are very important. You have to remember you have your brain stem right within your brain that may affect vital signs, doing frequent neurochecks, monitoring fluids. We know that there will be fluid shifts in the brain, and we want to make sure there's no increase for cerebral edema, as well as having fluid volume deficits. We need to be careful with positioning, whether the head of the bed should be slightly elevated, whether you're on the right side or left side, that will be denoted from the surgeon. Maintaining intact dressings, giving adequate pain management. These kids are going to have a whopping headache. There's not a reason why you need to be concerned about giving them adequate pain management when you're concerned about your neurochecks. If you're doing adequate neurochecks, whether your pupils dilate or not, are not going to be related to whether you have adequate pain medication. So don't be afraid to medicate these kids. They often have limited activities for a couple days and then will gradually go back to normal functioning with time. And it really is important to remember about that potential for residual disabilities. So they may have sensory, motor, intellectual deficits. They may have behavioral problems. And I will say I have seen this. Kids who have had head trauma or who have had brain tumors removed come back almost with a different personality. And a lot of them will have behavioral problems. So this is something that needs to be addressed. The parents need to be aware, and we need to make sure that we refer them for appropriate services. Next, we're going to talk about neuroblastoma. And neuroblastoma is a misnomer. You think neuro, so you think it's in your brain. But actually what happens is it is related to neural crests, crest cells, which is how it gets the neuro. But these cells actually are in your adrenal medulla, in your adrenal glands, and that's where the tumors originate. It is considered a silent tumor because more than 70% of children who are diagnosed with this are diagnosed secondary to symptoms from the metastasis site. So the tumors have already metastasized by the time it gets diagnosed. So often symptoms may include liver metastasis, it may metastasize to the lymph nodes, bone marrow, skeletal system. So you may end up having orthopedic problems that then diagnose a tumor that when they go back, they realize it's a secondary tumor from a neuroblastoma. Most of these kids are diagnosed by about 10, although most of these the mean age of diagnosis is actually in toddlerhood. So again, the goal of this is to identify the primary site, so finding the secondary site and moving backward and making sure that you've looked at all the potential sites through all the different mechanisms. So we're going to do CT scans and skeletal surveys. We're going to do bone marrow aspirations and biopsies. Urine catecholamines actually are positive in about 90% of patients with neuroblastoma. It makes sense. It's kind of kidney related. So this is somewhat a confirmatory test that gets you going in the right direction. And as with any disease, we want to stage it, we want to look at tumor progression, and we want to look at prognosis. And all of cancers today, I believe, are actually, if you are getting a biopsy, we actually look at the genotype and we can taper the chemotherapy based on the genotype of that particular tumor. So learning all the different names of all the chemotherapy drugs is almost a moot point, at least from my perspective, because based on what the genotype of that tumor is, the chemotherapy, the treatment, the radiation, the surgery, whatever that game plan is for that child, is going to be directed by what chemotherapeutic agents work best to treat that particular tumor. So it's very complex. We've come a long way, and it certainly has improved our outcomes for cancer. So when we look at neuroblastoma, the management really depends on how severe. Obviously, if you could catch this early, doing surgery, doing a biopsy, removing the tumor would be great. If you have intermediate development of disease, you have surgery and chemotherapy, and obviously, unfortunately, many of these kids have already had metastasis, and they may need surgery, chemotherapy, radiation, depending on where it's metastasized to, and some of these kids will have high-dose chemo followed by stem cell rescue. The younger the kid is when they're diagnosed, the better the survival. And part of that is they've had less time for potential metastasis, although younger children are harder to get a diagnosis from because they can't communicate well. So there are fewer children who are diagnosed younger. And the nursing considerations are very similar to leukemia and brain tumors, which is what we've talked about. But these kids, if they have had extensive disease, they may have a very poor prognosis, and obviously dealing with life-threatening illness, dealing with family coping, etc., are concerns from a nursing perspective. Retinoblastoma is the most common congenital malignant intraocular tumor in children, and it is an interesting thing. We, in the old days, I'm showing my age again, we always used to get that red light reflex, that red glow in your eyes when you photographed people. Now we have lights that go off first, so we don't get those in photographs. But that was frequently how children were picked up. You can see in the image at the top of the screen, there's a child, the right eye of the child has a red reflex and the left one doesn't have that red. That's suspicious. It's a white glow in the pupil. It's also called a cat's eye reflex, and that is suspicious of retinoblastoma. It usually occurs in kids less than 5, and you can see in the image below, the child on the one side has a reflex and the child and the other eye does not have that right eye doesn't have a reflex. So obviously the diagnosis depends on the extent of the disease. We hope to pick it up early so that we can prevent problems. We need a really good ophthalmological exam. We can do this initially in the ophthalmologist's office, but often has to be done under general anesthesia. We may also have to do an ultrasound or a CT scan of the orbit to see if there's any involvement of the bone in addition to the eye. And if there's metastasis, we may also have to do bone surveys and bone marrow aspirations if we think that there's bone affected. Now, I always get an ooh and ah in class when I show this image, and obviously this is not a child within the United States who has access to health care, who has had a tumor that has gone this far. This is what we're trying to prevent. But I think it's an important picture to show you to see the magnitude of what can happen if this particular problem is not treated. So the management really depends. What we hope is we can catch it early. We can do some focal intraocular therapy, whether that's cryotherapy, laser therapy, and frequently it's followed by chemotherapy, radiation. Sometimes we have to remove the eye, and they lose an eye, and the earlier you catch it, the better the prognosis, the better the appearance can be, the cosmetic appearance. And these kids actually do very, very well. They have a survival rate of about 90%. Many have decreased visual acuity. Some may have facial disfiguration. And again, they may have metastasis and secondary tumors, which become a concern. But all in all, these kids do well if we can pick it up early, and obviously they don't progress to this magnitude. Next, we're going to talk about Wilms tumor or nephroblastoma. It's the most common malignant intrarenal intra-abdominal tumor of children, and the peak diagnosis is about 6 years of age. Normally, these kids present with abdominal swelling and mass. It may be that they have intestinal obstruction and they realize a mass, so hopefully you would not see a patient who presented with this severe and acute of an abdomen. But obviously, you're going to get the symptoms of this disease based on history and physical. The key to this is you do not want to touch the abdomen. So this is the kid similar to the child with epiglottitis, where you're not going to let anyone with a laryngoscope near that child because you need to protect their airway because it may clamp down and you may occlude their airway. This is an indication where no matter how interested every first-year medical student is to palpate the abdomen of a kid with Wilms tumor, you're going to put a sign above the bed, you're going to lay on the patient and make sure that they do not touch the abdomen, because these tumors are usually loculated and very restricted within that area, and if people start palpating, you risk metastasis. So do not palpate the abdomen. Radiologically, in order to diagnose, we do abdominal ultrasounds, we do chest and CT, chest and abdominal CTs. Obviously, this tumor, because it's in the kidneys, can go up under the rib cage, which is why you need to do a chest CT. Obviously, we have to do hematologic, biochemical studies, urinalysis, and bone marrow aspiration. Metastasis is rare, but obviously you need to be monitoring for that because you wouldn't want to miss it. These children are treated usually with surgery followed by chemotherapy. They may do radiation before surgery with really large tumors or when there's a risk for metastasis. And they go in surgically. They remove the affected tumor, kidney, adrenal gland very carefully. Remember, this is in this sac that you don't really want to rupture. I use this term sac loosely. In addition, they have to look at the other kidney and the other adrenal gland and make sure that there's nothing suspicious on that side. They will biopsy regional lymph nodes, and they're going to remove anything that looks suspicious while they're in there, sew them back up. And obviously, these kids actually do pretty well if it's diagnosed early and there isn't metastasis. There's a survival rate of about 85%. Now we're going to talk a little bit about the two most common bone cancers we see, osteosarcoma and Ewing sarcoma. So osteosarcoma is the most common primary bone cancer. It's usually in the identified in the femur, but I have seen it in other parts. The diagnosis is based on CT scan or MRI, bone scans, as well as needle or surgical biopsy. When you look at the x-ray, these kids supposedly have a classic starburst pattern that makes it suspicious of of osteosarcoma. The treatment for this is to remove the affected bone, followed by chemotherapy. In the past, this particular cancer was treated often with amputation, and you will read that in the literature when you're looking at older literature. Today, we have become really, really competent. I shouldn't say we, I should say the orthopedic surgery people have become extremely competent, and amputation really is a last-ditch effort. These children are treated with limb-sparing surgeries. They remove the affected bone. They can actually put expandable temporary femurs in place, if it's a femur, where they can expand the bone while they grow and then do permanent surgery once they've reached their optimum height and their epiphyseal plates fuse. They have done extremely well. They are obviously at risk for infection, and these need to be modified depending on the age of the child. Fortunately, these cancers are diagnosed a little older, so these are in their teens usually, even into their early 20s. So they're not growing quite as much that we have to worry about catching up the bone growth as they, gain height over that period of time. If, however, in the long run, there is a need for amputation, you need to think about all the things you think about in adults with amputation. Phantom limb pain, as well as loss of movement and mobility and depression and all the things that go with amputation. Ewing sarcoma is the second most common malignant bone tumor. This is characterized by what they call an onion skin pattern, different from from osteosarcoma, which is that sunburst pattern. The diagnosis is the same as osteosarcoma, again, same workup, and the management, surgery again, radiation, chemotherapy, combination, and plus or minus stem cell transplantation. The prognosis for this is also fairly good, but it depends on the metastasis and the tumor size. I will say I have also seen kids with amputation secondary to Ewing sarcoma. So this is just a picture of some of the many faces of kids with cancer. When you think about cancer in children, I want you to remember how chemotherapy, radiation, the effects of cancer affect growth, missed school, developmental milestones. I want you to think about the long-term effects of cancer and radiation and chemotherapy as these children move into adulthood, because some of these kids end up with secondary cancers as a result of their primary cancer from their treatments. So you will see childhood cancers who come into children who have survived childhood cancers who come into adulthood who then end up with cancer as a result of their treatment of childhood cancer. So think about it carefully. There's a lot to learn. I will tell you, these children are incredibly strong. Their families are incredibly strong, and they have an awful lot to live for.